Hi, everyone, and welcome to the Sam Dever Podcast, episode 87. In this episode, I speak with Dr. Mitch Seruya. Dr. Seruya is an associate professor of surgery, neurosurgery, and orthopedics at Cedars Sinai Medical Center. He is also director of the Los Angeles Nerve Institute and program director of the Peripheral Nerve and Microsurgery Fellowship. This was an honor having Dr. Seruya on the podcast this evening, as he is the surgeon I worked with during my leg injury for my drop foot. He's doing incredible things. This was a very, very informative conversation, and I cannot wait for you all here to hear his journey and the journey Dr. Seruya and I have taken together through my leg injury. The book of the episode is Rebound: Train Your Mind to Bounce Back Stronger from Sports Injuries by Carrie Jackson Cheadle and Cindy Kuzma. I got this book right when I first got injured. It was a great resource, really inspiring for when you do get injured, to get back out there and recover and get back to the best version of yourself possible. If you want to listen to the podcast, be sure to follow us on Spotify and Apple Podcasts. If you want to watch the podcast, be sure to subscribe to our YouTube channel at youtube.com/@thesamdeverpodcast. Here's my conversation with Dr. Seruya. Dr. Mitch Seruya, welcome to the Sam Dever Podcast.
Thanks for having me. I appreciate it.
No, this is great. Little did we know that over 3 years ago,
right? I mean, that's how relationships form.
We'd be here podcasting, but I'm really excited for this one, not only because of who you are and the work you do and my experience with you, but this story of my injury has played a really big role in this podcast along the way. So it's a great moment here to have you here sitting. So thank you.
No, thanks, Sam. I really appreciate it. You know, for me, it's extra special to be here. One, because of, the relationship we've kind of gone through this journey together.
Yeah.
And just being able to kind of share with the greater public, nerve injuries, what's the real deal with them in terms of can they actually be fixed? And then some of the cool stuff we're doing out there, including how we helped you with the foot drop. So
absolutely.
I'm excited.
Yeah, that's a good template for the conversation. And I was thinking probably one of the best places to start is with your background, just for those that are tuning in, seeing you for the first time.
Yeah.
Could you take us through your background?
Yeah, I mean, it's interesting. A lot of people ask, oh, did you know when you were a kid you wanted to be a doctor, or did you know that you wanted to be a nerve surgeon? The answer is no to either. I mean, I was the first person in my family to complete college. And so, it's one thing, I see it now with my son, he's like a junior at Miami. It's nice to have someone that you can talk with and say, hey, what's the deal? How do I get to this step? How do I start thinking about pre-med? Because he's pre-med. But growing up, my dad was a blue collar worker, essentially a mechanic, worked on cars. And essentially I just worked with him in the shop. And so full disclosure, I did not have good hands on cars. So, I would say, I wouldn't use the word klutz, but I would just say I wasn't necessarily swift and I didn't have finesse when it came to cars. But nevertheless, working with my hands, I realized that I do want to be able to work with my hands. And then the idea of cars, especially when you're restoring cars, it's very reconstructive, right? You have a car, maybe the fender's busted, maybe the engine's out, taking it apart with my dad. Now he was the whiz, but kind of seeing that work ethic. And so I decided, to go to college, and I went at Columbia University in New York. And it was there that I basically was put on a track for biomedical engineering. And, I think to myself, how did I get to biomedical engineering? And in high school, I really enjoyed science, but I really did not have a love for humanities and art and stuff like that. And so my college advisor said, why aren't you looking at engineering schools? And it didn't even dawn on me. And he said, yeah, and why aren't you looking at Columbia? I mean, they have a great school. You can be in New York City. So I just went off a leap of faith. He said, hey, why don't you apply early decision? I had not seen the school. I didn't know much about the school. I knew it was Ivy League. And so I applied, and then I got in. And then when I arrived there, I said, oh, wow, it's actually a great school. It's in a great part of New York City. And that was my first time on campus, was literally just arriving with my bags. And so, was on the path of biomedical engineering. And then one of the things in my background is, I tore ligaments in my thumb and I had a hand injury. And so when I was like at, late stages of high school, I had hand surgery, and a hand surgeon really helped me. It's one thing when you lose your hand, and it's another thing to lose your thumb because your thumb is about half your hand function. So I injured my left thumb. My hand was like useless. And then a hand surgeon was able to kind of bring back function to me. And so while I was in the biomedical engineering track, I said to myself, all right, well, I like working with my hands. I saw what a hand surgeon had done for me. And I was doing pre-med, prerequisites. So I said, all right, I want to go to med school. And so I decided between college and med school to do a year off at Duke doing tissue engineering, research with stem cells. So the idea of trying to grow stem cells, coax them to become cartilage, to become bone, to become nerve. And because that was the big hype, this was like 2000. The idea of taking a stem cell, these aren't embryonic. This is not embryo. We all have them in our body. We call them mesenchymal or mesenchymal stem cells. They live in fat and connective tissue. So can we get them and turn them into different cells to be able to kind of replace parts? And so from Duke, I then matched at Columbia for med school. So I was back in New York, and I was there from '01 to '06, graduated. Now, in the midst of medical school, I'm thinking, all right, what do I want to do? Well, I like hand surgery. That's one thing. But I really like just in general, like head to toe anatomy. And so I was looking at the different specialties. And I remember one of my buddies from high school saying, you should go into plastic surgery, man. That's where the bucks are made. And I said, it's really not the reason why I'm going into medicine. I'm not going in to do cosmetic surgery. But every year I'd go back home to Jersey and you're like, hey man, come on, you should go into plastic surgery. And so I was very resistant to it. And then at some point I started looking into different specialties. And luckily, as a third year medical student, they match you into different surgical specialties to sort of see as what we call an elective. And so I got matched with plastic surgery. And so I was thinking Cosmo, it's just cosmetic, facelifts, neck lifts, tummy tucks. But then all of a sudden I was with the surgeon and he's working on a kid with a skull deformity. Essentially the skull's fused, it's not growing, the skull's misshapen, and that can affect brain development. And he's in the surgery creating room for the brain by breaking the bones and rearranging them with the neurosurgeon. I was like, okay, that's kind of interesting. He's working on the head. Then that same surgeon on another day is working on the breast for breast reconstruction. And so, and then all of a sudden I started seeing him working on other areas of the body. And I'm like, oh, wow, like this is a field that works head to toe. I like that. I like the idea of seeing all the different anatomy and trying to help someone and not feeling like you're closed off into like one space. And so from that, I ended up matching at Georgetown for plastic surgery. And what was very interesting that I had no idea is that at Georgetown, they had a peripheral nerve surgeon. So what's peripheral nerve? Those are nerves outside the brain, outside the spine, kind of like the nerves that run in our face, that run down our arms and our legs. And so as a resident, which is essentially someone who's training after medical school, you're paired up. Now in Georgetown, I'm paired up with a surgeon there named Ivan Duchik, who is a peripheral nerve expert. And every year we're working with him, 3 to 6 months. So imagine that for 6 years, 3 to 6 months, you're working with someone, you're getting like 18 months of exposure. And I'm seeing him decompress nerves in the head for migraines. I'm seeing him decompress nerves in the arms when it comes to carpal tunnel syndrome, which is compression of the median nerve in the hand, which can lead to numbness and tingling of the fingers, at the elbow, of the leg for foot drop. And so all of a sudden I'm like, wow, this is so cool. This guy is working head to toe on nerves and you're getting to see these before and after results. And the way they look, it's just like reinvigorating. Kind of see someone, kind of like the before and just how much it's affecting them with dysfunction, inability to, could be anything, can't feel things, can't move their fingers a certain way. And then the after effect in terms of like seeing them almost like a glow, kind of how much you've kind of impacted their life. It's really, I would say it's both emotional, psychological, but also physical in terms of how much it can affect a patient's outlook in life. And so I got to work with him. And from there I said, all right, I'm liking this nerve stuff, but also I still liked hand. And also at the same time, I also enjoy the craniofacial stuff. Like, what's craniofacial? That's cleft lip and palate. Those are kids that are born with defects of the lip or the palate. And so in my fourth year, I was just thinking, like, what am I going to do? It's a 6-year program. I like cleft and craniofacial, and I like hand. And at the time, I was gravitating towards kids. And so I said, all right, let me start looking at fellowships. That's basically training after residency. And so, like anything else, you start asking around, what are the good ones out there? And so you start asking people. One guy in particular that I knew from back in med school, I said, hey, you did a cleft and craniofacial fellowship. Like, where'd you go? He's like, I went to Miami. I said, great. How's Miami? He's like, Miami's good. But if you can go anywhere, if you don't have a wife or kids, why don't you look at Australia? I said, really, what's going on? He's like, oh, these guys in Melbourne, Australia, they're doing some crazy stuff. They're getting so much hands-on. They're basically operating at an attending level, but as a fellow. And I said, well, I have a wife, I have kids, and I have dogs, but that's not going to stop me. So I said, let me look at, if we can do it. So I basically just emailed the program director in Australia. His name is Andrew Greensmith. And I said, I'm just interested. I'm a fourth year. I have 2 more years of residency, but I just wanted to let you know about my interest. And so fast forward, then I'm on my hand rotation and I'm thinking, well, I still like hand. So then I start looking up pediatric hand fellowships. And then the first hit on Google was Melbourne, Australia, Royal Children's Hospital, the same hospital that I was looking at for the cleft and craniofacial stuff. So the next thing you know, I'm emailing that program director and I said, hi, Professor Coombs, I'm interested in the hand fellowship as well. I'd, emailed your colleague about the cleft and craniofacial. And so he's like, all right, mate, we'll take your interest into account and we'll let you know. So I didn't hear anything of it. And then about a half a year went by and Professor Coombs said, hey, I'm actually going to be in New York. I'm moving my son in. He's starting at Columbia. Do you want to meet up and we can do like an interview? And he's like, it could be for both fellowships. I said, awesome. And it was like fall. And we love fall in New York City. Brought my wife and the kids and we made it a trip. Met with Chris Coombs and we hit it off. And the next thing you know, I matched into both fellowships as a fourth year. So I had about 2 years of working on visas. And if anybody has dogs, there's quarantine in Australia. So that was a bit painful. Basically 6 months of blood testing. And then they had a quarantine for a month in Australia. And so there's a lot of legwork, made it happen, got to Australia. It was literally the best 2 years of our life in every way, in terms of professionally and personally. On the personal side, work-life balance in Australia, they have it right. They understand when to turn off, when to relax with a good bottle of wine and just kind of just enjoy the company around you. And so I really like that because for me, I was always going and going. There's a high intensity. There's basically, you're always kind of focused on your work and they kind of like made me reset that way. And I thought that was really helpful. And then also in terms of just the techniques, Australians, like anything else, they think out of the box. And so it was really nice to see techniques that I had not been exposed to, and in particular with nerves. So whether it's craniofacial, head and neck, which is going to lead to facial paralysis or migraines, or if it's the hand and microsurgery fellowship, you're basically working with injured nerves in the arms or legs. I got exposure that I had not gotten to in the US, namely nerve transfers that I was seeing for foot drop, nerve transfers for the face, for facial paralysis, and nerve transfers for brachial plexus injuries. So like, what are nerve transfers? It's essentially repurposing electricity or rerouting electricity from a expendable muscle to a muscle that needs it more importantly. And, as much as I had seen in Georgetown, I had not seen that level of nerve transfer techniques. And it was really like magic. Not that you see an immediate result, but when you do start to follow those patients 6 months, 9 months later, to kind of be like, wow, I cannot believe what's going on here. And I've said to myself, that's what I want to do. So now that was a long-winded answer, but it kind of just gives you an understanding of like how I even gravitated to nerve.
Yeah, no, that's incredible.
Yeah.
That's a lot deeper than your bio online.
Yeah, I mean, this is like the backstory,
The backstory, right? The real stuff here on the Sam Dever podcast.
Exactly. Yeah.
So to recap, you had no intention of even studying yours when you went into plastic surgery. You just went into the plastic surgery, and it just led you down.
Correct.
This road.
Full disclosure, if you would have asked me in medical school, oh, you're going to do a plastic surgery residency, what do they do? I would not have listed nerves as one of the types of, subspecialties in plastic surgery. And to get to your question, it's because, the layman or the average person in public, when they hear nerve, they're probably thinking neurosurgeon, right? Mm-hmm. In fact, a lot of times people will say, oh, he's a neurosurgeon. And I'll actually tell them, well, actually, I'm a plastic and reconstructive surgeon with subspecialty expertise in peripheral nerve surgery. And the reason why is, listen, kudos to neurosurgeons who also do it, but I don't want to, have people kind of mix that up. In terms of nerve surgery, peripheral nerves, you can approach that from 3 pathways. You could be a plastic and reconstructive surgeon because in the reconstructive realm, that captures anything, whether it's nerves, bone, tendons, muscle, skin. And so you can basically do a plastic surgery residency and then say, I'm going to do a fellowship in peripheral nerve. You can be a neurosurgeon, same idea, and say, I'm now going to do a subspecialty fellowship in peripheral nerve. Or you can be in orthopedics and do that as well. So multiple types of specialties can access peripheral nerve. And obviously you're going to see some of it in residency, but it's, I think, even more important in fellowship because fellowship is like the finishing touch. It's like polishing you for what ultimately is going to be your career.
So how many years of training was that total?
That's a lot. So we're talking 4 years of college.
Yep.
It was a year of tissue engineering research. 4 years of medical school. So we're at 9 right now. Mm-hmm. 6 years of plastic and reconstructive surgery residency. So we're at 15. 2 years of fellowship back to back in Australia. So that was 17 years post high school.
Wow.
So 17 years post high school. And, that's a lot. And I will say, juggling all of that, kudos to my wife and credit to her because it's not me. Is, we got married in my first year of medical school. We had our first kid as a second year in medical school. We had first kid between first and second year. We took a year off. Our second child was in my second year of medical school. So essentially medical school, we had kids. And my wife's like multitasking, basically taking care of both kids, but also working in New York City. And then, imagine shipping everyone. We're going to Australia, right? And we're in Georgetown. We're in Australia. Basically, everyone's growing up in the midst of us just trying to get our bearings. I went through medical school. My wife went through nursing school. And so, the running joke people say is, oh, must have been in the hospital like Grey's Anatomy. That's not what happened. We actually met on the beach when we were, I was a sophomore in college. And my wife is a senior in high school. And so we met on the beach through mutual friends. And then, basically from there, it just flourished. So it's just kind of a wild ride. I mean, essentially just young kids that we're growing up with, traveling DC, Australia, and somehow it all came together,
What type of dogs did you have? I'm a dog
guy.
guy.
So basically Boston Terriers.
Okay.
Yeah. So 2 Boston Terriers we brought with us, and we never grew up with dogs. It was really interesting. In fact, I was deathly afraid of dogs, as was my wife. So somebody says, how did it happen then? So basically we're in DC. It was like my 3rd year of residency, coming out of some place, see this really cute Boston Terrier. And even though I was afraid of dogs, I said to my wife, I mean, that's a beautiful dog. And she's like, yeah, actually it is. And then all of a sudden I'm thinking, well, maybe we should get a dog. And of course, I'm not really thinking, because if I would have thought about it, I'm working as a resident. So I'm like slaving away, long work hours, could be 80 to 100 hours in a week. And my wife's taking care of 2 kids. And here I go saying, all right, we're going to get a dog. And so next thing you know, we get a dog. And like, of course, my wife, who's like a trooper and a soldier, is basically just doing it, you know? Just to give another little nuance in terms of my wife, you know, as a fourth year medical student, you're doing electives where you're sort of going to other universities to see, do you want to do a residency there? And so I went to Stanford to see that residency program. And I remember my wife said, all right, I'll come out and visit with the kids. So my kids at the time were like 2 and 3 years old, something like that. And here's my wife basically hauling a double stroller in one arm that she's collapsed, and she's got the kids in the other, and she's boarding a flight and just doing it all, you know, and that was her, you know, she just rolls with it much better than me. I kind of freak out more, and she's just very chill and cool, and she does her thing. But we make a good match that way in terms of we complement each other.
I was just gonna say, it sounds like a pretty good team. You've assembled there.
We're a great team, but it's really more her than me. And but she's been like my rock. You need to have that. You know, people will ask, you know, ultimately, you know, in any relationship, there's a give and take, and there's a trust. There's got to be a trust there because, you know, if you think about it, I've seen this happen with my co-residents or medical school classmates. Is you have a partner, and if your partner doesn't understand the bigger picture or doesn't appreciate just how slow the timeline can be, that can lead to problems where they're like, well, why aren't you finishing up yet? You know, like, Sam, I don't want you to do a fellowship. We need to just finish and just get started. And I get it because, you know, in residency, it's not like you're making a huge living. So I get it when you're like, let's just rush out and just be done with it. But then you're kind of missing that essence of a fellowship, you know, like I have. So just to talk about fellowship training, you know, I started a peripheral nerve and microsurgery fellowship at Cedars, Sinai, because when you look at the layout of peripheral nerve fellowships in the US, there's like 5. And we're talking 5, 3 of them have started in the last 4 years. So it's not like there's a huge number of fellowships. But yet you say to yourself, where's the field going to be in 20 years or 40 years? Like, are we succession planning? Are we making sure to move the field forward in terms of innovation and getting the word out? Because in the peripheral nerve world, there's a lot of misconception and misunderstanding of nerve injuries. That goes for doctors and surgeons and, you know, nurses to just the general public and the general patient. And so when you look at it, if people don't finally understand how things work with nerves, it can propagate a false message in every way. One of the common false messages is nerves heal on their own. So you see that a lot. Oh, you have a nerve injury? Don't worry. Just give it time, and then it's just going to heal itself. And what most people don't realize is time is actually not on your side, because every month that goes by where the nerve has not healed is another month of muscle atrophy, because the nerve talks to muscle with electricity. And if the nerve is off, the muscle is off. If the muscle is off, it thins out. And then the nerves talk to muscles with what we call a motor end plate. It's the way the nerve lands on the muscle. And so these motor end plates, I don't know if you remember the analogy I gave you. You have an old school telephone wire, like a cord, and then you have the jack of that cord that goes into the receiver. Think about the receiver as the muscle, the cord is the nerve, and the jack is that interface between nerve and muscle. And these jacks, what we call motor end plates, they irreversibly, permanently disappear every month that goes by that there's no electricity in that nerve. And by the time you get to about 18 to 24 months after the onset of injury, there is almost no jacks left, to a point that even if you tap electricity into the phone cord, you're not going to hear anything on the other end of the line because there's no jack. So, you know, with fellowships, it's so important to, one, train the future leaders, and then at the same time, be able to kind of spread the gospel. You have to be able to get the word out. And that's, you know, honestly, what we're doing right now is getting the word out. Because it's a big shame, I'll tell you, every week. My whole practice is peripheral nerve. 100%. And every week I run a clinic Mondays and Fridays. And every week on a Monday and Friday, I'm having to break the news to somebody that unfortunately they're getting to us too late. They're getting to us 2, 3, 4 years after the onset of their injury. And it's not their fault. They're the ones that are being told, guided by their doctors, surgeons, or whoever, just give it time. It's not like someone's purposely trying to ruin their opportunity. It's just, unfortunately, doctors and healthcare providers don't simply understand nerve injuries. They don't understand the management of it. And just getting to the concept of why they don't heal on their own, people conflate all levels of nerve injury as the same, but they're not. You can have a nerve, which is essentially like a spaghetti, something like that, and you can pull on it a little bit. And you can have what's called a minor stretch injury. We call that neuropraxia. So what is that? A nerve itself is, think about it like a spaghetti or a coaxial cable. I like to use that. And the outer sheath is myelin. Myelin is basically the conducting layer for speed. It's the insulating layer. And so when a nerve is minorly stretched or pulled, that layer can break. And that nerve then is not working. That's a layer that will reconstitute or reform itself within 8 to 12 weeks. And so when people say nerves heal on their own, well, yeah, those types of injuries, a minor stretch, a break of the outer sheath of myelin, that can heal by itself in 8 to 12 weeks. But you know what? If more than 3 months go by and you still have a residual injury, then you don't have neuropraxia. You don't have a minor or mild stretch injury. You have either what's called axonotmesis or neurotmesis. So what does that mean? Remember the coaxial cable, big, thick, white rubber around the cable. And then inside, you got red wires and yellow wires and green wires. Well, axonotmesis is if you pull hard enough, internally, those wires break. Even though maybe the outer layer is still there, but the internal layer is broken. Well, that's not just myelin that just broke. That is the actual electrical carrying capability of that nerve. When you have broken wires inside, they don't just find themselves and start healing again. And so those are the types of injuries that need someone like me to help out with, or a peripheral nerve surgeon out there. Neurotmesis is that the nerve itself has been through and through cut or pulled so hard that it snaps, what we call a rupture, or if it's off the spinal cord, an avulsion. So those injuries, neurotmesis, which is a full snap through and through, or axonotmesis, the internal red, green, yellow wires break, those aren't going to heal on their own. And that's where you need a nerve reconstructive technique to, if you're trying to get the nerve back on, to restore muscle function, which is movement, or to restore feeling to the skin, you need to do a nerve reconstruction for that.
Going off of how you Googled and found Australia, I Googled Los Angeles drop foot and found you.
This is the beauty, I would say, of, where we are today with 21st century, innovation and development with computers and everything, and the web and everything, right? These are the positives.
Yeah, and you hit it on the head as far as like you said, like no one's purposefully keeping anyone in the dark about this. Just no one knows.
Yes.
And that's where I was. I just didn't know. Like there was no movement whatsoever. I don't know if it's a good segue to go into how you and I connected. But before then, when you got back to the States, what were the steps leading to where you are now?
Yeah. I mean, ultimately, it's like anything else. When you're in medical school and when you're in residency, there's an old adage that within 5 years, 50% of people will change jobs. And I remember saying to myself, that's not going to be me. Like, I'm going to be at a job and stay there. Well, I mean, I hate to, burst everyone's bubble, but basically I'm on job number 3 right now. Right. And that's because, and that kind of gets to how, like, why did that happen? And so I remember being in Australia, and like anything else, you want to get a job. Well, you start now emailing people, cold calling people, connecting, and figuring out what job is going to be a great fit. Now, obviously, there's a lot of different factors in a job, right? You're looking at the city and you're looking at the job itself and then the family fit. How does it all fit with the family? And so it was really interesting is that I said to myself, I want to be able to do hand and peripheral nerve. And the craniofacial stuff, the stuff that I really liked was facial paralysis. So I said, all right, let me start looking at jobs that kind of offer that. And, of the ones out there, Houston at Texas Children's, Baylor, College of Medicine, that seemed like a good fit in terms of the job. But city-wise, my wife and I were looking at each other, are we really like, Texans? Because we grew up on the coast. We grew up on the East Coast. I was born in Brooklyn, raised in Jersey. We lived in New York. We lived in DC. And then Australia, and I'm thinking Texas and Houston doesn't seem like, but, you're thinking to yourself, great job opportunity. Because what was the job? It was taking over and reestablishing a nerve center for brachial plexus injuries. Your brachial plexus are the nerves that run from your spine through your neck that feed your arm. And then to reestablish a clinic for facial paralysis. So I'm thinking, this is great. And so, just to talk about, the job, just 'cause this is a cool story. I remember about to leave Australia and, essentially I was guided as, mate, just get runs on the board. Don't go for a home run. Just get runs on the board. Don't try to be a hero. Try to just take on small cases that then build your reputation, which is great advice for anyone. And I said, all right, that's what I'm going to do. I'm not going to bite off more than I can chew. I'm going to get there and do that. So I remember my wife and I, we got to Houston. We're kind of shell shocked, like, okay, we're kind of getting used to that. And I had a dinner at my boss's house, my new boss, at his house the day before I'm starting. And so we're eating, and my wife, Shoshana, asked my boss, so, Dr. Ollier, I'm just curious, Mitch is on call for hand 24/7, except for like vacations. Is that a big deal? Because I'm the only pediatric hand surgeon covering Texas Children's. And he's like, no, don't worry about it. He's like, nobody ever calls you. It's like, I used to cover that for years. Nobody calls. I said, okay. So I go to bed for the first night, getting ready for the first day. And basically at 12:03 a.m., 3 minutes past midnight, technically I'm now employee of Texas Children's and Baylor. I get a phone call and I'm thinking, okay, you get woken up. Hello. And they said, yeah, is this Mitch? I said, yeah. And he said, oh, it's Dave Kachoyan. He's my new partner. He's like, well, I talked to Larry, who's my new boss, and he says, you're active now. And I said, okay. He's like, they're choppering and a kid. I said, okay. And I'm thinking, there's got to be a gag. I'm still thinking in my mind, this is a gag. Who's really calling me within minutes of being on the job? This kid's being choppered in. He's a 3-year-old. He fell off a lawnmower and it cut his hand off at the wrist. And I'm thinking, okay. And I'm still in denial that this is real. Still in denial. And so I'm like, well, when do you need me? And he's like, how quickly can you get here? And I said, 20 minutes. I'm still thinking, all right, at some point the gag's going to be up. It's just the haze. He's like, thanks so much. I'll see you there. And I'm like, oh my God, this is real. So imagine 1 minute you're the fellow, you're the trainee, and the next minute you're on and you're going. And I had not been in that operating room yet. I had a badge and that's about it. And so literally I'm driving towards Texas Children's Hospital and I start emailing all of my mentors from Australia because midnight in Houston was like midday in Australia. And to their credit, I said, I got a kid choppering in, hand cut off at the wrist. What do I do? And I got all this great sage advice. They emailed me back exactly what to do. All right, you're gonna have to remove the wrist bones. You're gonna have to wire the hand back onto the radius, which is your forearm bone. Grab vein grafts because you're gonna have to reconstruct the veins and the arteries, reconstruct the nerves, connect the tendons. So they gave me the whole order of events, and I got there. And it was completely daunting. You're getting into an operating room. It's like 1 a.m. or 12:30 a.m. And it's like chaos because you're bringing a kid in who unfortunately did not have his hand on ice. And so clock's ticking because muscle that does not have blood flow, if it's warm, goes through ischemia and it basically can die out. And so there I am. I walk in the operating room hearing all this uproar. And all of a sudden I hear my partner say, "Oh, our hand surgeon's here." And I'm not joking. I turned around too. All right. Because I'm thinking to myself, I'm not yet identifying myself as I'm the person now. I'm the one that everybody's relying on. And so you get in there, and I think it may have been 12 hours, could have been 15. We saved that kid's hand. And so we put it back on. The lawnmower had gone through the wrist, but also secondarily through the thumb around it. So the kid had a hand that needed to be put on, and then a thumb that needed to be put on the hand. So we saved the hand. The thumb died because it's like a double hit, one through here, one through the thumb. And the back of the hand, that skin was sheared off. So there I am. All right, you got to do it in steps. Get the hand back on, put a wire through it, connect veins, connect arteries, connect nerves. And then after surgery, you then build up, okay, how am I going to get the rest of the stuff? So 6 months later, instead of having a skin graft, which is just a sheet of skin that had temporized or kind of covered the hand temporarily, we transplanted tissue from his back. So skin, fat, and a blood vessel, and we're able to resurface the kid's hand, but he still had no thumb. And so 6 months later, getting into July or June, I transplanted his second toe to become his thumb. And so he essentially had his second toe now as his thumb, the skin and fat of his back resurfacing the back of his hand, and he had his hand. And while that was all going on, just in the interim of that year, I was loving the job. I had so much responsibility, and that initial first surgery, you grow a lot. You go from feeling nervous, feeling like, I don't know if I can do this. You're thrown in the fire. You just got to do it. It's like a cauldron, right? And so while I got that sage advice of, not taking too much on, it was thrown at me. So you either can kind of recede and go, kind of hide, or you can step up. And even if you make mistakes or, it doesn't go perfectly right, you're going to grow from it. And that was really an important experience for me. Honestly, it kind of changed my whole trajectory because it builds confidence, not overconfidence, but you're just feeling like I've had enough training where I know I can put my mind to this and figure this out. And so while that year was great in terms of the responsibility and the level of stuff we could do and help people, it wasn't good on my family. And the reason why is I'm there in the hospital, I'm enjoying it, I'm there working late hours, and yet my wife and kids are not fitting in with Houston. They're not fitting in with the weather. It's super humid. They're not fitting in with the city layout. It's not a layout of a city where you're going to be able to just go to the ocean, go to the mountains. It's very flat. And so I realized that as much as I'm enjoying myself, it's taking a toll on the family. And so serendipitously, my buddy who I trained with said, "Hey, USC and Children's LA have a job opening." And I said, "Okay, I'll look into it." He's like, "No, you don't understand." He called me like on a Tuesday. He's like, "You don't understand. If you don't interview for this position this week, it's done." And I said, "Dude, you're calling me," I think it was like Monday or Tuesday. I'm like, "You're calling me Monday or Tuesday. How can I get there? It's like 3 days from now." And so however this happened, and I believe in a higher power, I looked at my calendar. They messed up my schedule. I had nothing on the Friday. And so I'm like, okay, maybe this can happen. But again, I'm still like, I don't know. This is kind of crazy. It's my first year on the job. Do I really want to be looking at another job? And so I got a phone call within an hour or two of my buddy, and it's ultimately my new boss. So he says to me, "Hey, I heard you're maybe thinking about it." He's like, "You don't understand. If you don't come out and interview this week, we're giving the job to somebody else." And I said, "All right, I'm going to get on a plane." So I got on a plane and flew my wife and I out to Pasadena to basically stay in Pasadena and then interview at USC. And we were enamored with California. I mean, because to go from hot humidity, flat topography, no oceans, no mountains, to everything, in terms of what we had in Australia, we were just like, my God, like this feels like vacation, but this could be real life. This could be us. And so as much as I had a great job in Houston and I felt like I disappointed my boss. I just felt like for the collective good of the family, I got to make that decision. And so I remember saying to my wife, we need to make this decision. We just got to do it. And like anything else, as much as you want to make that decision, people are going to have some angst. They're going to be like, I don't know, like maybe we could just, we call it like Stockholm syndrome, right? You don't want to break out of that mold. My wife's like, well, maybe we could just do 5 more years in Houston. The kids will be then ready to be in high school, and then we can then move then. And I said, no, you don't understand. This is the window. If we don't get through this now, the window's closed. We're never going to have this opportunity again. And so we made the decision, boom, we're doing it. And so we ended up moving to LA, USC Children's LA. I was there for 5 years. And essentially, again, a lot of responsibility. I'm covering call 24/7, but ultimately feeling like I'm just stuck with call a lot, and when you're on call, imagine you can get woken up 11 p.m., midnight, whatever it is, and that's happening every week. And you're saying to yourself, all right, I like what I do, but I'm burning out and I'm not getting the opportunity to just take a step back, reflect on what I'm doing, and figure out the stuff that I really want to do. And how can I make the stuff that I really want to do go even better in terms of technical innovation? And so that was in the back of my mind. And while that's going on, I'm now at USC attending conferences. So every Friday we have grand rounds. And so while I'm there, one of the legends in the field, Randy Sherman, Dr. Randy Sherman, he'd be in the audience. And he was one of these old school guys. Everyone knew him because he was like an innovator when it came to flap surgery. Flaps are basically tissue. It could be skin, fat, muscle, the idea of transporting them or transplanting them. He kind of was in LA in the heyday in the 80s, working on this stuff, perfecting it. And so he's in the audience and he's seeing what I'm doing. He's seeing these cases because the residents will present it. He's like, wow, this is amazing. Like, you did this, you did that. Like, this is so cool. And we don't have it at Cedars. And so that was in the back of my mind. And then he started to really take me under his wing and say to me, this kind of stuff we really need. We need someone who does nerves, because he was building a microsurgical mecca almost, in terms of he wanted Cedars Sinai to be the microsurgical center on the West Coast. And in microsurgery, which is the idea of microscopically working on tissue, there's an avenue for arteries and veins, nerves. And with arteries and veins, you could be transplanting bone, muscle, skin, and nerves are its own beast. And so he's like, we really need somebody that can handle that. Head to toe nerves, kids and adults. And I said to myself, that sounds awesome, because for me, I knew that that's ultimately what I wanted to do, because the nerve stuff, the way it worked, in terms of how much you could help patients, paralysis, pain, numbness, and what you can do for that. I said, I want to be able to do that kind of stuff and not have to have as much of the burden of the call. Because the overnight call, when you're getting woken up and then you're trying to do your elective surgery the next day, it's very challenging. And so Randy saw that. He saw that my work-life balance was not right. And he's like, trust me. He's like, if you come over, your family's going to be that much happier. And he was right. And so to his credit, I really owe him for where I am today at Cedars Sinai, because I was basically tasked with, okay, you're associate professor of surgery. Your job is to create a peripheral nerve and microsurgery fellowship. We want you to direct that, train people. We want you to grow the center. So this Los Angeles Nerve Institute, which is the institute that I created to dedicate to nerve injuries in LA, California, and the greater area, he wanted me to bring that to Cedars and make that at Cedars. And so it was really exciting. And ultimately, I really owe him that. Unfortunately, he passed away tragically this past July. So that's been a real challenge. It's very hard to, replace somebody like that who's got so many years of experience and wisdom, and honestly was like a dad for me on the West Coast in terms of life advice and just checking in. Somebody who really cared, was vested, not because they're forced to, not because they have to act it and feel like you're acting. He generally just lived and breathed for the well-being of others. And so that I would say has been the saddest thing in my time in terms of just seeing that happen. But I'm trying to pay it forward and trying to follow what he's mentored me in, of getting the word out, whether it's just education, training, research. So
I'm very sorry to hear that about him. But it's like we do meet those people in our lives that get us to those positions, and we don't know how it happens. We don't know why sometimes, but here you are, and it sounds like he put you and left you in a great position to where you are right now.
yeah, I mean, I'm a believer in a higher power, and
Mhm.
there's no doubt in my mind, that's a messenger, or a messenger in Hebrew is an angel, right?
Mm.
So there's no doubt, like what he did for me, it's transformational in terms of what he did for my life. I can never repay that.
Yeah. Well, that is an incredible backstory. Like again, I did not know really much of that at all, and I think it's fascinating. And what I love about this story so far too is I hope people really consider. I mean, 17 years, right, of training.
Correct.
We live in a world now where instant gratification. How quick can I get there? But with this type of thing, that doesn't exist. Like you have to do the work.
Yes.
I want the person operating on me to have done the work.
What's interesting is that idea of delayed gratification.
Mm-hmm.
If you have that kind of personality, then you make the perfect peripheral nerve surgeon, because peripheral nerve surgery is also delayed gratification. Perfect example, whether it's you or another patient who has a foot drop surgery where nerves are connected, that surgery can be done and we can send you to a physical therapist. And most physical therapists think, oh, Sam's had tendon work, bone work, joint work. It immediately works because it's that kind of stuff. But what most people don't understand are nerve surgery isn't as if you just connect two nerves and away it's on and your nerve's working and you have no more problems. It's an evolution. It literally could take 9 to 12 to 18 months to finally see the fruits of our labor. And so that really is meant for the personality of, I can wait. I can have confidence, but I also have trust that what we've done is going to lead to something meaningful. And then there's a lot of, guiding and pulling people off the ledge, because I joke around about it, but in my surgery, in nerve surgery, there's kind of different phases. There's the honeymoon phase, like, wow, I had this great surgery and, I can't wait. And then there's that phase of buyer's remorse, like, oh my God, I'm not seeing any result month 1, month 2, month 3. Like, what did I do? Why did I do that surgery? I don't think it worked. Maybe something broke in there. Maybe he didn't know what he was doing. And then I'm having to talk people off the ledge and then kind of re-engage them, because I'm a big believer in it's mind and body. And what if you have optimism and hope, and if you're spiritually there and connected, I do think it translates into a more complete and meaningful recovery. And so there's a lot of that, having to explain to patients, you're not going to see a result right away. And I even had that conversation today. Someone says, how do you deal with that? When you do an operation and you don't see a result, do you get anxious? And I said, to be honest, when I first started, yes. Because when you first do your first nerve surgery, it's not like you have any kind of experience to fall back on. Yeah, you were a resident, you were a fellow, you kind of saw some things, but it's another thing to be the one driving, right? And so there I am doing my first nerve surgery, and I'm like, okay, I think everything was connected. All right, month 1, no result yet. All right, well, I think everything went right. Month 2, month 3, then it starts creeping in. Some doubt creeps in. You're still like, oh man, like I'm not seeing anything yet. And then you start emailing people like, is this right? Like I'm not seeing a result at 3 months. I said, don't worry, mate. Like, just she'll be right. Just let it play out. Let the electricity, because what happens is when you connect two nerves, just to give some insight, the first month is hibernation, it's latency. Nerves are asleep from the fact that you've manipulated them, they're swollen from surgery, and they turn off. And so for a month, nothing happens. Then, after a month, at an inch a month, the electricity in the donor nerve starts to travel at an inch a month through the target nerve. Now, where the nerves are connected, it's not like they're connected right where the nerve hits the muscle. And so, however far away the connection is, it could be 4 or 5 inches away. Well, it was a month of hibernation and 4 to 5 months. So 4 to 5 inches. So that's 5 months or so to get the electrical connection to actually hit the front doorstep of the muscle. But as we know, you don't just hit the front doorstep. You got to enter the home. You got to go into each room in the home. On the first floor, turn on the light. You got to go on the second floor and on the third floor. So what does that mean for a muscle? A muscle has length, it's got width, it's got thickness. All of that needs to be electrified. And so that's why it's a months to almost years process of seeing what we want to see with it. But the first time you actually finally see that evolve and it works, you're like, okay, I get it. Now I can breathe a little easier, but not that easy. I mean, you do the second and third time, again, the doubt creeps in, all right, but eventually you start to get adjusted to the time frame for when you're actually going to see results. And then that helps me then guide patients or teach my fellows so that they understand it. Because if not, everyone starts to pull the trigger on, oh my God, something's wrong. Can you go back in and see if the connection is still connected? Or can we get an EMG and nerve study? Because I don't think there's any electricity in there. And I say to them, you know what? You can hold off on the nerve and EMG study, the electromyogram study, because there shouldn't be electricity in that yet. It hasn't been long enough.
I think that's a perfect segue to use me coming to you as a case study, if you will, for this conversation. So yeah, I had I call it was a devastating knee injury, dislocated the knee, and not only hurt the peroneal nerve, which I had no idea existed. They told me in the hospital, oh, you have foot drop or you have a peroneal nerve jam. I'm like, a what?
Yeah, exactly, right? Like, what is that?
And this is what's like, you don't think about, and that's why I have so much gratitude now, because you don't think about these things when you're not hurt. You don't think about, oh, there's actually a nerve that I can lift my foot off the ground to walk. Well, what happens when that goes out?
Yeah.
You can't lift your foot.
It's devastating.
It's devastating. And it's, and so I'm dealing with all components of the leg injury, but the foot drop I was the most concerned about during the recovery, because that's something that it's not moving at all. The other stuff going on, you're like, okay, I know it hurts. I'm in a lot of pain, but eventually this will start to get better. But this is one where it's just complete unknown. And I remember going on Google, you go on YouTube, you go and you just start researching. And I agree with you. Like, we do live in this is one of the amazing things about technology, that we have all the answers to the world that have ever been.
On Dr. Google.
On Dr. Google. But it's, I have to throw this out there. I have seen in offices where they say, don't confuse my medical degree with your Google search. So,
right? Because there can be some of that, right?
Right.
Oh, I read this on Google.
Yeah.
And then you're like, okay.
No, I just need Google to get to you.
Yes.
So, and I'm looking and I go through, I'm like, because there really wasn't much out there at all. But then when I found you in the Los Angeles Nerve Institute, I'm like, oh, this is exactly
this
it.
is me. Yeah.
Yeah. So I remember calling and they could get me in there. They got me in on my birthday.
Oh, I didn't know that.
Yeah, it was my birthday the day I came to you 3 years ago.
I mean, I guess I was a good present in the end, but kind of weird at the time, like spending my birthday in a doctor's office.
Yeah. We're heading to Cedars, Sinai for my birthday. but it was just grateful just to find you. And I remember going to you and still, you still don't quite see the light at the end of the tunnel, but I realized that there was one.
Yeah.
I can't see it, but going to you, you're like, hey, here's what we're going to do. We're going to try. And then what I'll do is I'll just set you up and pass it to you here.
Yeah.
So we did the first surgery. And I remember you told me the first time I went, because I came 3 months after the injury, and you told me, I remember you saying, you're in the sweet spot.
Yes.
You came to me, because even if you would have came to me right away, don't you have to wait 3 months anyway to see if anything happens?
So, I mean, that gets to the idea of how long do you wait for nerve injuries, right? So we talked about there are different flavors of nerve injury. One of them was that neuropraxia, which is demyelination. The myelin itself goes. But we said that reforms itself by 8 to 12 weeks. So if you had a minor injury, then by 3 months, we should know, which means we shouldn't be acting before then. And so, as you know, you came in around month 3. And so I said, oh, you still have a foot drop. That means it's more severe. You either have that axonotmesis, which is the internal breakage, or neurotmesis, where the nerves actually snapped. And so ultimately, when we're looking at it, we're saying to ourselves, well, we don't want to overcall it, but when we know you need something, the question is, what do we do? And so in your case, it's month 3, and your mechanism of injury was, I think you were hiking, correct?
I was running down a hiking trail.
Got it.
Which I will never do again.
Mind you, I literally did the Los Leones hike last weekend with my wife in Malibu, and we see people running. And my wife's like, how do people do that? I don't know how they do it. Maybe we're just not fit. But, that mechanism of injury, while it is severe, is not the same thing like what I see with motorcycle crashes or some kind of blown out knee like they were jet skiing. So in your case, I said, all right, you obviously dislocated the knee and that caused a stretch injury, but maybe we can go ahead and decompress this nerve and see if it just turns back on. Because what's a nerve decompression? You're releasing any scar tissue that could have formed from your knee ligament injury, and you're creating more space for a nerve and saying, nerve, I've created some space for you. You don't like pressure on you, because when there's pressure, it stops electrical signaling. Let's see if Sam can turn on his own. And because you were only at 3 months after injury, we had the opportunity, we had the luxury of time to say, let's decompress you, give you 3 months to see if you do turn on. Because again, a nerve should turn back on by 3 months. And so we did the decompression, but as you know, it did not yield the kind of result we were looking for. And so now we're thinking we got to bump it up to a more active, proactive kind of surgery. Not decompress you and let your nerve turn back on. We got to pull some power out of something expendable and tap it into these muscles that need it more. And so that kind of gets to foot drop nerve surgery. And it's been an evolution for me. The first one I did was 2014, so 10 years ago. I did it on a young kid. And I remember saying to myself, well, I trained in Melbourne and there was a certain technique, 2 incisions, one on the outside of the leg to get to the targets. Because what's a foot drop, right? A foot, instead of going up and out to lift your foot up to clear the ground, doesn't have the electricity in that common perineal nerve. Your common perineal nerve is part of your sciatic, and it allows your foot to go up and out. If it's not on, then your foot goes down and in. And for walking and running, it's a constant tit for tat where you're up and down, up and down, up and out. You're basically constantly going like this to generate locomotion to start walking. But if your foot is only down and in, you don't have force to generate. You don't have balance. You're tripping. And so we say to ourselves, all right, well, we want to turn on those muscles. In Australia, there was a 2 incision technique. 1 incision on the outer leg to get to the target muscles, a muscle that lifts the foot up, what we call dorsiflexion, and a muscle to roll the ankle out, what we call eversion. And the second incision one is on the calf to access the nerves to the toes that bend. That's a different nerve. That's called the tibial nerve. Also part of the sciatic, but not involved in the foot drop injury. So we're saying, let's repurpose electricity from the toe flexors, the toe benders, and say, toes, we're going to take some electricity from you. And instead of toe bending, we're now going to reroute it to the ankle to get the ankle up and the ankle out. So somebody will ask me, don't you need your toes? And the truth of the matter is we're not climbing trees anymore, right? We're not apes or monkeys climbing trees. You don't need your lesser toes. That's anything but your big toe. Your big toe does have an important role for push off for running, but the big toe, like the other toes, has two sets of electricity that make it bend. We can take electricity from one and leave the other. Toe can still bend. It's just not going to bend completely. But ultimately, having toe electricity doesn't get you anywhere if you can't lift your ankle up because you're still not walking or running. So I would rather give up some toe electricity, the benders, so that you can get your ankle up and out. And so that's a technique I learned in Australia. But then you get to the US and the Mayo Clinic had a single incision technique. And I'm like, oh, well, not many people like having two scars. Maybe I'll do that one instead. So this is kind of the naivety in me, the inexperience in me that says, I'm going to do that technique. So I did that technique for about 2 or 3 years. And I'm like, God, it's not really working that well. And I said to myself, well, why isn't it working well? Well, I have one incision and I'm trying to get to the target nerve and I'm trying to get to the donor nerve. And I feel like I can't see either that well. And it's not very specific. I'm just taking some of the toe electricity and I'm tapping it into the main common perineal nerve, big nerve. How do I know it's actually turning on the dorsiflexion and the eversion? It's sort of just going into the main nerve. And so I realized, man, I should have never overlooked the technique that I learned in Australia. Now, in Australia, we learned the technique of turning on one muscle, the tibialis anterior, for dorsiflexion. But something to keep in mind with whether it's a foot, a boat, a plane, is you got to be balanced in all vectors. The tibialis anterior muscle lifts the ankle up, but also rolls it in. And so if you only turn on that muscle, somebody's foot would go up and in, but it wouldn't be rolling out and kind of level. So I realized you really need to turn on more than one muscle. You want to turn on your dorsiflexor to lift your ankle up. You want to turn on your everter, which is your peroneus brevis, to roll it out. You even want to turn on your toe extensors because our toes can act like secondary dorsiflexors if possible. So every patient's different with how much toe electricity, the benders, you can give up to turn on as many of these targets. But I said to myself, you know what? We need to holistically turn on more of these muscles than we're turning on. Because what's the fallback to if you don't get a nerve surgery? You get what's called a tendon transfer. So what has that been? Well, historically, the nerve surgeries have had poor results. And I've written articles on why. We won't get into all of that now. But let's just say bad track record for nerve surgery to turn on the foot drop. So Orthopedics was saying, well, let's just take another tendon that's expendable, that normally inverts your ankle, and let's just repurpose it. Have it haul up the foot, connected to the dorsiflexor, connected to the everter. And so now one tendon is going to serve 2 or 3 functions. And obviously it's better than nothing, right? Think about it almost like an internal splint. It's holding your ankle up, but it's not turning on the natural muscles. It's not turning on the exact muscles that were turned off and paralyzed. It's essentially just giving you an opportunity to maybe get out of that splint, what we call an ankle foot orthosis, a brace, so that you're not relying on that to walk. But I said to myself, that's not a great operation. As a purist, I want to turn the nerve back on and I want those muscles to turn back on because that's going to give you the best longevity and going to give you the most normal looking gait. The way that your foot goes up and down will more normally come back if you turn on the native muscles than to rely on a tendon transfer, which is essentially cutting a tendon and then bringing that rope to the front of the ankle to lift it up. And so that's kind of the evolution of that technique. And I said, that's what we're going to do on you. And, I appreciate you having that confidence and saying, all right, I trust this guy. We're going to go forward with it. And you had the right attitude, which is, I know it's going to take a while. I know it's going to be long. And at the end of the day, I have to work on my, post-operative rehabilitation and therapy. But as you put it in and as you, have that confidence and that trust, it's going to bear fruit, and that's where you got. So, it's just been an awesome, experience for both of us, because for me, literally you've kind of lived through this evolution. When I got to you, I think you were within the first 10 patients that I had made that transition from the single incision technique to a 2 incision technique, and not 2 incisions to turn on one muscle, 2 incisions to now turn on multiple muscles to get fully a balanced foot and ankle. So that's kind of where we got with you.
I'm hanging on to every word because I remember when you first broke it down for me. It's like I was with you, but I was like, we're going to do what again? like houses, we're going to steal electricity. Okay.
Yeah.
But, and I think really for me, obviously being able to meet you and just seeing like, okay, he knows his stuff. He knows what he's doing here. This is the first time, like, I feel like I'm really like someone knows what's going on with this specific thing.
Which, by the way, not to cut you off, is a huge thing.
Yeah.
Because just to get to where patients like yourself go, people with nerve injuries are constantly being ping-ponged around town. Ping-pong. Like, oh, I don't really do that. I'm going to send you to this person.
Right.
You go to that person. I don't really do that. I don't really know what to do for that foot drop. I think maybe you're supposed to give it time. So the patients are constantly just being ping-ponged all over. Their head's spinning. They're getting a lot of false or incomplete information. And then they come and see me, and it's kind of a mixed blessing. All of a sudden, I'm throwing at them all this information. Nerve injuries don't usually heal on their own. They're time sensitive when it comes to the need to get to them. If I want to get to them, we're probably going to have to steal electricity from somewhere else. The result's not going to be there right away. Electricity moves at 1 inch a month. The ultimate result is 3 years later. That hits them really hard. In one hand, they're appreciating it because they haven't heard any of this before. And in another way also, they're like, okay, this guy gets it. I can kind of trust that. But on the other hand, there's almost this, I'm not going to say animosity, but they're upset about, why was I told that it was just going to heal on its own? Or why did somebody just observe me for a year or two? Why am I only hearing about you now? Weren't you in LA all this time? Yes. And yet the patient's like, why didn't my doctor know about you? And so it is kind of a mixed blessing, but you took it the right way, which is, there's a guy here that could potentially help me. And this is the first time I'm hearing about some solutions.
Yeah, it was really that confidence in our first meeting as well. It's like, because you were just like, yep, we're gonna do it. I remember you're like, yep, we're going to surgery. I'm like, huh? I called my mom. I'm like, we're going to surgery. But it's like, it's to me probably and as I try to think back, you think about, well, what's the alternative?
Yeah,
you just wait. Maybe something happens. But then when you describe the time window, it's like, well, if you wait past that and nothing happens, you're in a, and I should know the answer to that. AFO, what does AFO stand for?
Yeah. So basically what happens, like, what are the other options out there? Because people ask, like anybody else, if I don't do the surgery, what are the other options? Well, option one is you got to stabilize your foot so you're not tripping and so that you can just walk. So that's an AFO, an ankle foot orthosis. Ankle and foot orthosis means an ankle and foot brace. What is that? It's basically holding your ankle at 90 degrees. So think about it like the old school Chuck Converse high top. It holds you at 90. Because what does that mean? Your ankle isn't unstable. You're not just going to turn it and tear a ligament or something. You're not going to trip and fall. But at the same time, it's not dynamic. You're not going up and down. So what does that mean? You can walk in it. And what does it do? It inserts into any shoe or sneaker, but you're not running. And then what's option two? Well, you can go ahead and get a tendon transfer with orthopedics. Think about it like an internal AFO, in my opinion. Now, some orthopedics will disagree with me, and I respect that. They may have better outcomes than I'm thinking. But I've also had other orthopedists who level with me and say it's never that good of a result. It gets them out of an AFO, but it's not as if they're ever really running again or feeling like they have good longevity in what they're doing. And so I said, all right, what do we have to lose here? We can do the surgery on you, Sam. Take your toe flex for electricity. Try to turn on these muscles. Let's say it fails. What are your fallbacks? You can still do your AFO. You could still do the tendon transfer with orthopedics. What does it cost you? a round of anesthesia, or 2 if you have 2 surgeries, 2 scars, and the time. You're putting trust in me that for months to maybe a year or so, it'll take to get the foot to turn on. Could even take a year and a half, 2 years to really get some good function. So it's going to cost you time. So is it the right surgery for an 85-year-old? No, right? Because maybe they don't have that luxury of, do I really want to wait a year and a half to see a result? But young person, highly motivated. Just to give an example of highly motivated individuals, I had a gentleman fly in this week from Florida, young 26-year-old gentleman who heard about me from another patient and was told, like, if you're going to have nerve transfer surgery for foot drop, this is the guy. So he flew in Monday, consult, Tuesday, surgery. Friday, today, post-op check, drains removed. He's now back tomorrow on a plane to Florida. I have a gentleman 2 weeks from now who wants to go through the same cycle from Georgia. And so young people are going to be motivated to say, I don't want to be in the brace for the rest of my life. I don't really want the idea of one tendon trying to pull on 2 or 3. Like, how does that work? I really would like to get the natural muscles that have been paralyzed back on. And so that's the beauty of this. If you're motivated, you don't have to necessarily be young, but just motivated, patient, and understanding that it's not just going to go like that. And if you have that leap of faith with me, I think you'll find that it pays off. Can't guarantee it. I would say that generally speaking, it works. Who have been my failures? The very first patient I did it on got a subpar result. The only other time, and it's kind of a moving target, professional NFL player, that maybe it was too aggressive with the kinds of weights and activities he was doing shortly after surgery. But he's still improving, and it's possible he could actually get to where exactly we want to be. But short of that, I've not seen failures when it comes to, it just didn't work. I haven't seen it.
And you know, it's, I remember, and I've told you this story, I can't remember if it was the 3 or 4 month mark. It was somewhere around there. And I was laying in my bed right in there. I was after physical therapy, icing up or whatever I was doing. I remember just seeing the first, I'm like, am I imagining that?
Yeah. Or is that real?
Or is that real? Flicker of my foot. I'm like, maybe I moved it with my leg. Maybe that's what's happening. But then I start pulling. I think I emailed you pretty quickly.
like, wow, it's on.
Yeah. And then it all starts. And even as we're talking it out right now, like I understand because I've been through the whole thing now. So now it all makes sense what you did. As opposed to when I first heard, I'm like, huh?
Well, it's got to be powerful, you know, and I'm sure it was like with you and the same thing as other patients tell me. The moment that you first see that first movement, like you said, there's denial, like maybe it's not really there, or maybe my body's jostling those, you know, foot and ankle to move. But when you finally see, like, no, this is real, for at least most patients, it's a change in the frame of mind. Like, oh, wow, this is actually working. There's hope here. This crazy surgeon wasn't just FOS. You know, there's something real going on. And now I get to look forward to the next phase of what happens.
Yeah. And, you know, I have to give a shout out to Debbie, who is my physical therapist. She's been on this program, and it really is. And you are completely right about the mindset. And it for me personally, it was a spiritual experience, because especially after you have the surgery and you're just waiting and you're like, okay, what's going to happen here? But you still have to go do those exercises at physical therapy, and you may not see results for a very, very long time, but just consistently going, doing the work. You know that there's a light somewhere. You can't really see it, but you know, you just have to keep going. And then when I got that first flicker, then it was like game on.
Yeah. Yeah.
Like,
I mean, it's like, all right, let's
how
do
many
this.
exercises am I allowed to do? Let's do everything.
Yeah. Because I mean, you're alluding to ultimately, what do you have to do with this, right? Mm-hmm. You have to retrain your mind to think, he just stole electricity from my toe benders and he gave it to my ankle to go up and out. So if I want to get my ankle up and out to walk, I got to think about clawing or bending my toes to do that. And at first, as you know, it's a very deliberate, okay, I'm bending my toes to lift my ankle up and out. And then eventually you're not even having to think about it. It's just happening. Your body almost reflexively is figuring out, oh, that's what I'm doing and that's working. Let me just keep doing that. But in the beginning, as you know, what are you doing? You're practicing on your uninjured side and your injured side, because at first your injured side isn't going to work. So you're like, all right, I'm bending my toes, lifting ankle up. I'm not seeing anything. But the whole point is to retrain your mind. So you can retrain your mind on your good side, develop those habits. So then when you start doing it on your injured side, when it actually starts turning on, whether it's 6 months out, 9 months out, or 12 months out, you're ahead of the game because you've already reframed your mind as to how to walk.
And can we dive a little bit? You're explaining the toe pairing exercises, right? Because
Yes.
I remember doing those in your office and in physical therapy. Could you explain why are we?
Yeah. So we're
doing that on both
essentially
sides?
in surgery, what we had done is we stole electricity. We took the electricity that was going into the toes to bend. We've cut it to that muscle and then taken that nerve and now connected it to the nerve that talks to the muscles that go up and out. So when your body is saying, I want to move my dorsiflexor, I want to get my ankle up, I have to think, well, what's my signal? What's the origin of my electricity? The origin of my electricity is my toe bender because I've just repurposed it. So now you have to think, I got to pair toe bending with the function that I want. You're pairing the donor function with the target. The target is dorsiflexion going up or eversion rolling out. But in the beginning, if you just decide that I'm going to start learning that on the injured side because the electricity travels at an inch a month or a foot a year, it's not working yet. So if you just try it while you're sitting down, you'll be like, I'm not seeing any movement. This isn't really working. What's the point of this? Because you can't pair clawing toes or bending toes with going up and out. Because on the injured side, you can't go up and out yet. But on your good side, you can do all that. You can bend your toes, you can lift your ankle up and out. So you're working on your good side and you're also trying on your injured side. And your injured side at first is not doing anything. And then, as you know, things start to wake up. Could be 6 months out, 9 months out, whenever it is. And you're like, oh, wow, this is working. Well, now that stuff I learned on the uninjured side, I can keep doing on the injured side. And now I can actually reinforce that connection between the donor nerve, which is the strong nerve, the toe bender, with the target nerve, which is the injured, the paralyzed muscle, the stuff that's going up and out.
And what, one thing I would tell anyone, going through a recovery of an injury too, and especially the ones that take a while like this isn't something you're going to see day by day or week by week, maybe month by month. But when they happen, and I'll never forget, I was walking this block actually, and I had been wearing an AFO. And I think it was probably a little less than a year from the surgery. And I'm like, it was like intuitive. It was so, I'll never forget this moment. Just start walking without the AFO. And I was walking without the AFO. And
Which is huge.
Yeah. And
huge.
it just, my body just not, but I had been doing all the work to get to that point. But just that moment. And then once you're there, you're there.
I can't imagine because I'm not in that shoe, but it's got to be powerful. It's got to put you on a high almost because it's like a spiritual, physical high. Because that is the goal, right? You don't want to be dependent. It's kind of like what you alluded to before about a foot drop or an injury. All of us walk around just seemingly going through our day, not necessarily appreciating what we have, especially health-wise. I know this for me when I injured my hand as like a 17-year-old kid thinking that you're invincible, and then you tear ligaments in your hand and your thumb, and you're like, I don't have a thumb now. Oh my God, I don't really have the use of my left hand. But it takes that moment of the injury to put things in perspective. Same thing with the foot drop. We just walk around thinking we're just walking, doing our thing. But what if you can't lift your foot up? Now you're relying on this brace, this device sitting in your shoe or sneaker to get you to walk. But as you know, it's clunky, it's there, it's an object. You want to just wear whatever you want to wear. And you don't want to have to rely on something. And yet here you are, a young guy having to rely on a brace potentially for the rest of your life.
I didn't even know if I'd wear dress shoes ever again.
Right.
You know,
Because
and
it's not gonna, because the brace is not going to fit in that.
yeah, and they can be heavier, and
Yeah.
yeah, it's something you know you never thought about, but to be at this moment now, it'll be 3 years in June since I had the surgery, and I mean, doing what I'm doing now. And again, it's a fun. I gotta watch myself because I get those moments where I'm like, let's get out there and let's just attack it. And it's like, all right, maybe not go up to 10 on the treadmill. You could probably do it, but let's just keep it around 8.
Yeah, everything in moderation.
Moderation, but to be able, and especially the running as of late too. That was something I was just grateful to be able to walk. Because if you didn't know me and didn't know I had the injury and you're just looking at me, no one really would know. But to be able to be doing moderate jogging on flat surfaces now.
Huge.
I emphasize flat,
not
flat. Going downhill.
Yeah.
It's so, I had to quote Debbie, the physical therapist. I go, it's surreal. She's like, it's not surreal, it's Seruya.
It's amazing. I mean, I love that line, by the way.
Yeah.
Appreciate that. I think, like you said, foot drop, it can be life altering. And if you think about it, there's over 100,000 people a year affected just like you are with foot drop. And yet they're not being plugged in with potential nerve surgery. They're being told, here's the AFO. This is what you have. And while you're wearing it, let's see if your nerve heals. And yet that is not necessarily what any of us want, right? Is the idea of, hey, Sam, for the rest of your life, you got this brace and that's what you have to deal with. And so the moment you come out of that, you're like, oh my God, I can actually wear a dress shoe. I can go for a jog and I'm doing it on my own for an injury that was once thought of as permanent and irreversible. It's powerful. It's amazing, and that's what I love, because for me, I could have just given up on my failed results in the first, 4 or 5 years of my practice and said, this nerve stuff, it just doesn't work for foot drop. And yet the scientist in me said, I don't understand. Nerve surgery works for other areas. Why doesn't it work for the peroneal nerve for foot drop? And luckily I've put into my papers, I've written some papers on this, exactly all the details for why previous techniques have failed. And the important thing is not simply to understand why previous techniques have failed, but then say, how can I do it differently and better to then answer those limitations to make the surgery more reliable? And so fortuitously, yesterday, was part 2 of my papers. Part 1 was differential diagnosis of foot drop. What are the different mechanisms of injury that lead to it? What's the natural history of those injuries? Meaning, do they heal on their own? What's the surgical track record? Because with foot drop, they're not all the same flavor. Anything that leads to less electricity in the muscles that lift your ankle up and out is a foot drop. Electrical source is your spine. So people can have disc herniation, compression of the spine nerve, specifically L4 or L5. That is the original power source to the peroneal nerve that controls muscles lifting up and out. So a patient can have an L4 or L5 disc herniation, which is essentially the cushion, which is a disc between bones, pushes out and starts to press against the nerve root, and that drops electricity, and that can lead to a foot drop. But you can have a different patient, goes in for a hip procedure, wakes up with a foot drop. What happened to them? There's something called the sciatic nerve. That's the biggest peripheral nerve in our body. It controls all of the muscles from the knee down. And in particular, the sciatic nerve becomes the peroneal to the front of the leg or the tibial in the back. Well, patient goes in for a hip procedure. Their hip is being frog-legged. It's being flexed and opened out, and they're on the table for 2 or 3 or 4 hours. That puts the sciatic nerve on stretch as it's coursing out of its pelvis around a bony canal and into the back of the thigh. Well, that sciatic nerve can be on stretch, it can be compressed, and it turns off, and then you get a foot drop. Or lastly, you can have a peroneal nerve injury. So the peroneal nerve is going from the back of the knee to the front of the leg, and that nerve is at harm's risk for a knee dislocation injury or ligament injury like yourself. It could be at risk if somebody's being tackled and there's a strike to the side of the leg, or again, the nerve is hit, or it can be transected in surgery accidentally. And so there are different flavors of foot drop. And that first paper talks about the different flavors. What's the natural history, meaning what happens if you just leave at the time? And ultimately, the punchline with natural history is about 70%, 70, so 70% don't heal on their own. So that's the majority. And so if 70% don't heal on their own, well, how's surgery? Surgical track record for nerve issues is, unfortunately, it does not lead to a meaningful result. And so ultimately what people are finding is that if the surgery is not working with the current conditions, well, what can we do to make that better? And so ultimately we then get to paper number 2. And in paper 2, what we're really looking at is what has been some of the downsides to nerve transfer surgery, which is essentially the idea of rerouting electricity, and why has that not worked well? What have we been doing wrong? And we go through each avenue in the paper, and then how do we address it? How do we fix those problems to then make this a stronger result? Yeah. So that's kind of like the evolution of where we got with the foot drop. And, papers 1 and 2 came out in the last couple of months. It's really exciting. It's great to be here, to be able to kind of put this all together. And it's just been an awesome journey.
Yeah. And can these papers be viewed online? Or
Oh, yeah.
Yeah.
So basically, Journal of Reconstructive Microsurgery invited me as a author to talk about these, concepts. And so on Journal of Reconstructive Microsurgery, you can go online and these papers are available. Obviously you have to have access. It could be an institutional access through a university, a college, or it may require, to purchase a single article. But if anybody ever reaches out to me, and obviously I'll leave my contact information with you, I can send that to them.
Okay.
Yeah.
And I think this is another, well, I have one question before I ask this next question is those moments where that period of the results may not be where you wanted them to be. What was driving you to figure this out?
Basically, this comes back to childhood. So I was the sore loser. I was the kid that couldn't deal with failure, couldn't deal with not getting the best of anything, whether it was a video game or sports or school. And I was always like, I got to be better than this. There's got to be a way to get to the next level. And so while that may have been a weakness growing up to some degree, right? Because you got to be able to accept failure and sort of realize that you're not the best at X, Y, or Z. I kind of use that as a strength later on. So I don't give up, right? And it kind of comes to that old adage where I'd always hear this: if it was easy, everyone would be doing it. And so I said to myself, all right, well, I know this is hard and in some ways impossible, but I want to make this possible. And so that's what drove me, just internal drive. And not like I needed to show it to anyone. I don't need to say, look at me, look at me. It was more of, I know this can be done. I'm just not fully appreciating why just yet. Things aren't working, but I'm going to get there.
It's really inspirational, as we've talked about on this podcast before too. I use the example, it's like the 4-minute mile, right? Like for years they say it can't be done. No one can do it. But what happened the second that first person ran the 4-minute mile? People are running the 4-minute mile left and right. But it takes that one person to, even when they're being called crazy or no, we can't be done, it's impossible. That one person that's like, no, this is going to happen.
And that happens. This happens in medicine. Just give a couple of examples. One in particular, ear reconstruction. So kids can be born without an ear. Traditionally, they're reconstructed with the cartilage in our ribs. And so that was the way. Carve ribs into an ear, place it here. And so what people were finding is, well, the ribs resorb, they warp. What you put in is not what it looks like 10 years later or even 5 years later. And so a surgeon here in LA, Dr. John Reinish, said, why are we using ribs? Why aren't we using something that's a little bit more with longevity? How about a medical grade porous polyethylene, which is biocompatible, will hold up better, and I'm going to use that. And so he started doing it. And at first, not even at first, for years, people were like, he's crazy. He doesn't know what he's doing. He's putting people at risk. They're going to get an infection. It's not going to work. It's not going to work. It's not going to hold up. And obviously at first when he started doing it, yeah, his outcomes were not where they are today. Did he have some complications? Yes, like anybody would. But to his credit, he didn't give up. He said, I'm going to keep at it. And literally today, his procedure, in my opinion, is the standard of care, or at least where people want to go with it. People are routinely flying in to watch how he does surgery. People in LA are chomping at the bit to figure out how to do surgery like he does. And so that's one example. But another personal example, you're right about people think you're crazy. When I started to first do this surgery and put results out, not even first, this is still going on now. People will see it and start to say, no, like that's natural recovery. Like in your case, well, yeah, I know he connected the nerves, but there were probably other nerves that were still going into your muscles. And that's what happened, natural recovery. And I said, natural recovery, if you look at my technique, I'm literally cutting the nerves going into your muscles, the only nerves talking to your muscles, and I'm connecting them with a new power source. Where's the natural recovery? Oh, well, there must have been some extra nerves that go into that muscle that you didn't see. Really? Well, why don't you actually look at the anatomical diagrams and you'll find, no, there's generally one large nerve, maybe one extra branch, but one large nerve in general. And so that would go on for years. I'd present my data, present the technique, and people would be like, I don't know about that. Only now, after, because people would think, all right, if you're a crackpot, well, even at some point, you're going to stop doing it. But now, we're in like 40 or 50 patients in here. I'm still doing it. I'm still talking about it. Am I really that crazy? Or am I seeing results like yourself, like yours, to say, no, this can work. Does it work every single time? No. Like anything else, no surgery is foolproof. No surgery can give you 100% great results. And so you have to say to yourself, all right, well, this is a reliable technique. It's not perfect, but I need to get the word out. And that's what I've tried to do, whether it's through podcasts like this, writing papers, sharing them, getting on Instagram to share these papers with people, present our findings in research conferences, and just inviting people to come out and take a look. I've had surgeons that come out to actually see what we're doing. And then some of them realize, oh, I wasn't doing it like that. I didn't realize that that's how you do it.
And that goes back to the importance of the fellowship. You're saying making sure that the newer generations of medical professionals are aware of this and passing the information along.
It's huge. I mean, if you think about it, I was invited as a visiting professor at University of Michigan, a very top tier plastic surgery program. And I remember I had a couple of different talks. One of them was case examples. I went head to toe. And I remember one of the residents raised their hand and they said, remind me again, you did a plastic surgery residency? And I said, yeah, just like you guys. They said, how did you get all of that experience? We're not seeing all of that. And I said, well, obviously there was residency, but then I did first fellowship craniofacial, which is head and neck. So I'm seeing the head and neck nerve injuries, migraines, facial paralysis. And then I did a second fellowship, hand and microsurgery, and that's going upper extremities and lower. And so I had to cobble together residency, multiple fellowships to give me the experience and versatility to go head to toe. But imagine, like the fellowship I have, my fellow is working under me. She gets to see head to toe without having to do two fellowships. And that's what we really want out of peripheral nerve training programs is a one-stop shop. Doesn't have to be one surgeon, it could be 5 surgeons, but ultimately giving that trainee the opportunity to, one, understand in general nerve injuries, diagnosis, management, and then specifically technically, how do we address facial paralysis? How do we address phrenic nerve palsy for the diaphragm? How do we address foot drop? And that's kind of the beauty and what I really enjoy about it is working with my fellow every week, and I should say, thank you, Harjo, because Harjo, Dr. Tour, she's been amazing to have. And last year was Dr. Baba Juni. I don't know if you met him, but ultimately the fellows push you. They keep you honest. They're raising the bar. They're helping you with research ideas. They're really energizing. And not just that, they're going to be the leaders of tomorrow. It's not going to be me, and they can spread the gospel. So
that's what we're doing.
Yeah.
We always joke when I come in, like we're going to go on tour.
Go on tour, right? Bring the band.
When you need me to come on stage and walk,
Dude, and here's the tour, man. We're doing it.
Yes, this is the beginning of that. And there is another question. So I think you just set it up perfectly. What is the future of this? And I know this can go a million different directions. I don't know if robotics and AI play a picture, or
I think all of what you're alluding to. I mean, look at what Elon Musk is doing with Neuralink, right? The idea of implanting a device in the brain that maps the brain to understand where is the electrical center to control the arm, where is the electrical center to control the leg or the face. Now imagine you've mapped it out, and now you implant it in someone who has a spinal cord injury or paralysis of a certain area of the body. Well, that Neuralink can electrically charge the brain. And if you have another implant in whichever location that you're dealing with, now they're talking to each other. Now you're actually moving things. Or some people are using exoskeletons. Imagine you had a device that goes on top of your forearm or your hand, and now you have a Neuralink device that's talking to the exoskeleton. It's getting your fingers to move a certain way. The Luke Skywalker arm, what people talk about, are we there with myoelectrics, which is the idea of the bionic arm? In my opinion, we're not there yet, but that's another area of exploration. How do you integrate a electrical biological prosthetic that can be interfacing with the native nerves in the body to allow someone to replace their hand or their foot or whatever missing body part and make it move again? And then obviously stem cell and tissue engineering, kind of that research I was looking at in 2000. We haven't gotten where we want to go with it, but can you coax cells to become nerves to replace the area of damage, right? People are looking into that. Spinal cord injuries. Can you inject stem cells into the spinal cord within the first 24 to 48 hours, maybe with stem cells, maybe with other growth components to get it to repair the damaged area? So people are looking all into this. I look at myself more as a translational researcher, meaning are there certain things that I can immediately modify and do to make things go even better? Just to give an example, we're trying to figure out ways to speed up nerve healing. Because as you know, we talk about it an inch a month or a foot a year. Are there ways of making that go faster? Well, interesting as an aside, in plastic surgery, we do transplants. We're not doing organs, but we're doing face transplants, arms and legs. And as an aside, people have found that when you do transplants, nerves wake up faster than if it was just a nerve cut on somebody else. So what's the difference? People are on immunosuppression when they're doing a transplant. So clearly these immunosuppressive drugs, tacrolimus, other types of things like that are basically enhancing healing. So can those same transplant drugs be given to a nerve injury patient after you've done a nerve surgery on them to make things go faster? We're looking at that. So there's lots of cool stuff coming out there. Is it going to happen like that? No, but 20 years from now, the field's going to change a lot.
It just gives me more peace of mind too, to know that there's people such as yourself working on this stuff.
Yeah.
It's like, it's so important. Like it's so, and especially when I came across you and what you're doing, I'm like, man, like people need to know, like people need to know about this. And I'm sure there's other medical professionals and other areas that are like you that are like, no, I'm going to figure out this specific thing.
Yeah. I mean, I think you need to have people that are driven, but you also need to have people that are team players and willing to talk to other people. And like we talked about, phrenic nerve injuries, right? The idea that electricity is not talking to your diaphragm. You don't have good breathing. If your diaphragm's not on, you can't create a space for your lungs to expand. So I could have looked at it and said, well, I'm going to come up with an idea and just do it. But then I realized thoracic surgeons, they're working in the chest cavity all the time. Why don't I pair up And now I'm working with Dr. Andrew Branley at Cedars, and he came up with a clever idea with robotics to let's robotically, minimally invasively get to the phrenic nerve in the chest cavity, access it so that I can connect some rib nerves to turn it on. And so that's the cool thing, right? Teamwork, multidisciplinary approach. And that's a whole other flavor, right? The idea of we see this all the time. You work with another surgeon in a different field, like, oh, what's that gadget? What are you doing? Oh, that's pretty cool. Maybe we can start to use it this way. And the same thing goes for them. They may say to me, oh, what am I doing? Oh, maybe what I'm doing, that technique can be applied to what they're doing. So there's a lot of cross-pollination that way.
You go to a lot of conferences and stuff like that?
Yeah, I used to go a lot more. I mean, these days I try to go to the big meeting, the American Society of Peripheral Nerve Surgeons. That happens every January. It's typically in a nice place. It's coming up in Hawaii. So that's going to be nice next January. So I try to obviously be at that meeting because that is kind of a centralized meeting for nerves. And it's a great meeting. Obviously get to reconnect with people, get to hear about what's going on in other parts of the world. And it just gives you some ideas, some food for thought.
Yeah, and I like to your Australian roots.
Yeah.
How you're able to contact those guys and how quickly they were able to get information to you.
That was huge. Honestly, huge. Because midnight, if I had tried to email someone from Georgetown,
what a story.
Who's going to answer that, right? They're sleeping. People are sleeping. So that was really, really cool. Serendipity, right?
Yeah, and I think it's just a beautiful perspective too of humanity too. Like from people from all around the world. Like we're all human.
Yeah.
Trying to figure these things.
Looking out for each
how
other.
powerful we are when we all come together and
yeah, it's a great story
and everything. And
yeah,
this has been spectacular. Is there anything else you wanted to add?
No,
share?
honestly, I just appreciate you all, your team, Eric, also just basically giving me the floor to kind of share this experience, the story. And I really think things are meant to be. There's no coincidences. I think we were meant to connect, and we're going to take the story forward.
This
to
is
be
just
continued.
part one. Eric, did you have any questions?
I mean, a million, but no, it was a fantastic story because I wasn't even sure. I couldn't even really grasp like what your injury is and like what like, the side effects were. I had no idea about the surgery, like specifically what the surgery was, that there's the 3-month period. It was awesome hearing about it. It really was.
Yeah.
I'm sure there's a lot of people that are going to be healed from a lot of traumatic injuries. Yeah, in the future. So it's really cool.
Even one whole stone we didn't lift up, but obviously
Let's lift it.
Lift it up. Nerve pain, right? People can go in for whatever it is, orthopedic procedure, some procedure, wake up and say, my God, what's this burning and tingling pain? And of course, they're first told, give it time, which is true. Let's see if the nerve heals. But imagine it's 3 or 6 months later, you're like, my God, I'm chewing through narcotics. I don't want to be on oxy. I'm on oxy. I have this nerve pain. There's tingling. There's vibration. And of course, they go back to their surgeon. And it's not like the surgeon deliberately tried to hurt the nerve, but it's in the vicinity of the surgery. Now, again, nerve injuries are not easily appreciated. So when they go to their surgeon and say, I'm in a lot of pain, it's not like the surgeon immediately connects it and says, oh, it's that nerve. That's your problem. And you know what? You need to go to Seruya at the Los Angeles Nerve Institute. They don't realize that. So this patient start ping-ponging around town and they're not sure what to do with it. Some of them get to the point where they're not sleeping and they're suicidal from the amount of pain. I've literally had patients say, I'm ready to just jump through that window right there if we can't try to get a hold on this. And like anything else, then you got to play detective. What kind of surgery did you have? All right, well, let's see which nerves are in that vicinity. Let's see, narrow it down to 3. I think it's one of these 3 nerves. How can we figure that out? Well, we know patients have pain. It's almost constant. All right, let's send you for an injection. Image guided with radiology. They're going to take a needle and instill local anesthetic, Marcaine, lidocaine. It's going to chemically turn that nerve off briefly. So whatever pain signals are running through, it's going to stop it briefly. And then sure enough, after you trial and error, you're like, oh, it's that one nerve. Okay, so that nerve must have been damaged. What can we do about it? Well, if it's an expendable nerve, let's go ahead and let's go in there and cut back on it. cut out the zone of damage, get into a healthy area, and now we don't want to piss the nerve off because we've cut it out. Let's wrap it with a little piece of muscle. Nerves like to talk to muscle. Let's calm it down that way. You can help a lot of people that way. And so that's what I've done. And what's interesting is some of those patients, in my opinion, everyone's grateful, whether it's a paralysis patient or a pain patient. Some of those are on a whole other level of gratitude because they were literally ready to take their own life. They're ready to OD on pills, jump through something, end their life. Because while it sucks having any kind of nerve injury, paralysis obviously is terrible, but it presents itself situationally. Like I have a foot drop, I can't walk. All right, well, if I'm sitting in a chair, temporarily for the moment, I'm okay. Still not great, but you're okay. But when you're in pain, and that's 24/7, that literally ruins your outlook in every way. You can't function, you're irritable. You don't want to be around people. And you're on a lot of pills, which means it's dumbing you down, knocking you out. And so that's the amazing thing also. A whole other aspect is there are actual treatments for nerve damage. Unfortunately, not on the spine. If the nerve's damaged in the spine and it's creating pain, I can't help with that. That's a spine surgeon that needs to go in there. If the nerve damage in the spine is causing paralysis, I can help with. We just bypass that zone of injury, pull electricity closer to where the problem is and put it in. But pain outside the spine, in the periphery, that can be helped potentially with nerve surgery. So that's a whole other avenue.
You know, I'm actually glad you brought that up because to give you, so really quick, his name's Eric Jorgensen. He lives next door. This used to be his apartment. My bed was right here when this injury happened. And now we do the podcast from it. It's a whole story.
Yeah.
So you have these people along your journey and the pain, the nerve pain was so bad that first month of and maybe you can explain maybe why I was feeling it. It's funny because I forgot about it till you brought. I'm like, oh yeah, I didn't sleep for like 30 days straight. It was so bad. So nerve pain, it's unlike because you can't. It'd be like someone was turning it on. It'd go down
like
a little
electrocuted.
bit. Electrocuted, exactly. Then they'd turn it right, and it didn't. And nighttime seemed to be the worst.
So you're alluding to nighttime because during the day, we're busy with things. We're distracted. Mm-hmm. Someone's talking to you. You're on your phone. You may be typing. You may be doing tasks and activities. You're task oriented. At night, you're sitting in bed. You're just trying to sleep. You're trying to wind down. And yet you have somebody taking a car battery and shocking you. And that's not easy to just ignore. And so that's why nighttime is typically the worst time for nerve pain. And plus, if you think about it, let's say you're on your leg all day. The toils of the day, the inflammation, all of that swelling, it starts to stack up and really push that nerve over its edge. And that's by the end of the day. Yeah. So I'm glad we turned over that rock because that was a good stone to turn over. But no, I really appreciate it. It's awesome. I'm excited about where we go with this. I'm excited to have your audience hear more about this. Yeah. And I look forward to seeing it.
No, and I definitely view you as you're going to have to pop in here.
Yeah.
Every so often, give us the update because I think it is fascinating the work you do. I'm very grateful again that I Googled Los Angeles foot drop, but it was in a city where you were at, and it was unfortunate the injury happened, but what I'm very grateful and blessed in, I had every right person there, you being one of them, to help me get through it.
Yeah, and like you alluded to, your physical therapist, Debbie, right? Yeah. I mean, you got to have the right person rehabilitating the patient.
Yeah.
You can have a great surgery and a poor result if the follow-through with physical and occupational therapy is not there. So, hats off to Debbie. You have a great team around you. Yeah. And, I think hopefully for any patient that's seeking nerve surgery, they're going to find themselves the right fit for when it comes to the rehab.
Yeah, absolutely. And I always give the guests the last word, but before I do, where can people find you? Where's the best place for them to go, reach out to you, learn more about your work? Where should they go?
So, it's been a baby of mine, but www.losangelesnerve.com or lanerve.com, either one you can do. On there is a whole repository of my practice, the types of nerve conditions we treat, the types of nerve procedures that are out there. There are some videos of before and afters. And so that's a great resource just in general. If anybody is looking at the medical literature, there's something called PubMed. You can actually, on PubMed, type in somebody's name. You can put in Seruya, M, and then you can see the articles out there. You'll notice the first 2 articles that show up are the most recent ones, and those are directly related to foot drop. Obviously, I have other articles out there when it comes to nerve injuries, but whatever kind of nerve injury you're dealing with, you can go on PubMed. And then lastly, obviously on Instagram, I'm not as active with that, but I do post from time to time. I've been meaning to put out some of my before and after videos on Instagram. Maybe I'll finally get to it. And so I think those are all excellent resources.
Well, we'll be definitely tagging you. Get prepared to see some notifications.
What is that Instagram handle? Do you know?
Oh, the Instagram handle is Los Angeles Nerve Institute. That is my, handle. And the other obviously is my personal handle, Mitch.Seruya. Either one, they could always reach out to me, but Los Angeles Nerve Institute is kind of the one to look after. And I've had patients, like I said, this guy from Georgia just reached out from that. So it happens, and it's happening more often. And honestly, patients will start to connect with other patients too. It's another great resource. I'm always happy to put people in touch. Rather than hearing it from me, talk to another patient.
Absolutely.
I know you've done that, right?
Yeah, no, absolutely. And just having, talking to them and having that conversation, like, I know you can't see the light at the end of the tunnel, but it's there.
Yeah.
You just have to stay. I say, stay the course, do the exercises, don't do the don'ts.
Yeah, exactly.
Do the do's,
Follow the program.
Follow the protocol.
Yeah.
And and hopefully with what we're doing right here, it just really just gives me more insight to, I've been through it and experienced it, but how many people are out there that have questions and don't have hope right now and don't. So hopefully something from this, whether it's the long form or one of the, how many ever clips we're going to clip out of this.
Yeah, let's
just
do it, man.
However they find it. So I always give the guests the last word. It can be as deep or as shallow as you want. It can be about absolutely anything. The last word is yours.
Oh, I would just say, strike the right kind of work-life balance. It took me a long time to get where I am today. At first, I was all business, no pleasure, and then not enough about family time. And I realized this more and more. Like, you have to be able to wind down and then focus on your family, friends, and relationships. And I'm finally just getting there now. And so I just say to everyone, people who hear it at a young age, be like, oh yeah, sure, I'll get to that. But, get to it sooner, because ultimately that's what you have in the end. The work is great and helping patients, but ultimately it's the people around you, right? So.
Awesome. I love it. Well, I've loved to hear more in depth about your story. I look forward to continuing the conversation. And again, I thank you, Dr. Seruya, for everything you've done.
Thanks again, Sam. Thanks, Eric.
Yeah.
Appreciate it. All right.
Thank you. Hi, everyone. Sam Dever, the Sam Dever Podcast here, and I just want to thank you for checking out this episode. To watch and listen to future episodes, be sure to follow us on Spotify and Apple Podcasts, and subscribe to our YouTube channel at youtube.com/@thesamdeverpodcast. Thank you so much. See you soon.